Okay, welcome to our science group presentation. Originally, we were hoping to have a talk on the effects of radiation from a radiation specialist, but he's sick, so we're very happy and lucky to get a replacement speaker today, who I'll introduce in a minute. I wanted to thank a lot of people who made this series possible. The Hurlbut Church has been wonderful to us. We thank Paul Womack and Debbie Caruso for helping us get all this together. And without Zach Stallsmith, we would have nothing. He's done magic, allowing us to zoom in, zoom out, and come here in person and have this hybrid system so that we were able to make this quick switch. We also want to thank Dr. Larry Rizzolo, Dr. Teresa Kammerman for doing our Zoom responses. We thank the Allison Hopper for doing a brochure and website. Mark Wensler, who's partnered with us with his climate change initiative and provided us with speakers and a lot of support. And we also want to, let's see, I've got Mark Wensler, Allison, and I think, the audience, yeah, thank you for being an audience and for supporting us financially and in other ways. Today's speaker is Dr. John Haughton. He has a medical degree from the University of Michigan. He also has a degree in engineering. He did his residency in rehabilitation medicine at the University of Washington, where he was chief resident. His specialty is physical medicine and rehabilitation. He has over 30 years of experience, and his medical practice is currently in Buffalo, New York, as I understand it. His current work focuses on effective clinical care approaches that quiet inflammatory and fibrotic processes. He has a summer home in Chautauqua and served on the Chautauqua Institute Board of Trustees and Foundation Board from 2014 to 2022. And today we'll talk to us about long COVID. So without further ado, we will ask Dr. Haughton to make his presentation, and thank you all for being here.
Thanks very much. Appreciate it. And it turns out that first of all, I'm John Haughton, and would rather be on grounds than off, but there you go. It turns out that this talk is also very relevant to radiation therapy and fibrosis. The body ends up ultimately having a balance and a teeter-totter between building things and breaking them down, and then sometimes getting them stuck in a fibrotic mush. And after radiation, that happens as well. And I'll actually touch on that very briefly in the remarks. So what I hope to share here is what long COVID is, how it can be treated, and it can be, and how it fits into the other body systems and body processes that go on. And this work is from a personal and a professional background. Overall, it's really critical that we go after trying to treat long COVID. It is estimated there are about 20 million people in the US, probably 400 million people across the world that have it at this point. Originally, it was about 7 out of 100 people who had COVID would get it. Now it's down to about 3 out of 100, but the incidence goes up because people are getting infected multiple times. There are no FDA-approved treatments, but that said, there are ways that people are combating the underlying root issues as well as the some of the symptoms and sequelae of it. So the body ends up having a really this teeter-totter balance between the builder and the killer. And you can think of processes. There's something called sepsis, when bacteria overtakes the body and it ultimately can shut down and it can kill you pretty fast. Can somebody mute? Okay. It can happen pretty fast, and that occurs. Long COVID is weeks to months, so you have the disease, and by definition, after COVID, if you still have symptoms at 12 weeks, that starts getting into long COVID. And then aging is some of these body processes happening over years and decades. And it may well be that it's the same process that's acting at different speeds, depending on the burden of the disease. So if you have a pile of bacteria that are replicating and the lipopolysaccharide or LPS turns on something called toll-like 4 receptor and all of a sudden lights up the immune system, that happens right away like fireworks. On the other hand, long COVID, the spike can also fit into that receptor, but does it more slowly and happens to do it more in the white cells, not all the cells. And so that could be more of a smoldering process. And aging ends up, you get accumulated damage in the cells, and eventually you get senescence that drives cells to continue to put out inflammatory parts, but they stop replicating. And that may be one of the body's ways that it keeps cancer from happening when cells get out of whack. The picture on the right shows a mouse model of looking at what does it look like in terms of what areas are infected from COVID on the left and from the flu on the right. And the flu ends up going primarily in the lungs and the liver. And you can see the COVID, the spike goes all over the place. And it goes all over the place because it gets inside of white blood cells, and white blood cells go all over the place. And then they get into the small vessels. And when they get into the small vessels, they attach to the walls. And I'll go into this in more detail, but as a broad picture. And then when you get inflammation in the cell walls, you end up driving lack of blood flow. Red blood cells can't get through the capillaries. And it turns out that just that hypoxia by itself drives further inflammation. So you really get a flywheel effect of a spike, whether from vaccine that's gone awry in some people or infection, then starts an inflammatory process, and somebody might have an underlying inflammatory process with autoimmunity, rheumatoid arthritis, lupus, or a predilection in those types of directions, Sjögren's syndrome. And then diabetes does it too with small vessel disease and inflammation. And then when you get the hypoxia, it pushes the inflammation, and then that just keeps the cycle going. And the same process happens in chronic wounds. At a more broad level, you can see it when treating people clinically. There's long COVID is gaining more and more momentum and importance. As I was looking through, putting some pieces together for this, pulled out the National Academy's publication from this summer. It's the first time that there's a full disease state definition, and the National Academies, when they publish something, it means that it matters to the country, and that's why they do it. And it turns out there's a little bit of a Chautauqua connection. Harvey Feinberg was here, one of the week 9s on medicine a few years back. And I think he has some cousins who live back over by Miller Park. From a clinical perspective, does somebody have long COVID? So what does that mean? There isn't a single blood test for it. There is you can do combinations of looking at the differential on the white blood cells, so the lymphocyte counts to the macrophages. You can look at cytokines, things like C-reactive proteins. Sometimes they're normal, sometimes not. Things like IL-6 or interleukin-6 can flare up. But a lot of it's symptom-driven, which might be fatigue, it might be headaches, it might be dizziness standing up, the GI symptoms, there could be cardiac issues, and other comorbidities. And then what kind of treatment can be done for it? From a clinical perspective, you've got somebody in front of you, you can chase the different symptoms, but wouldn't it be nice to get at the underlying issue? And that's where you start to think about quieting inflammation, but doing it in a way that's not going to cause trouble. Because if you quiet inflammation too fast, or if there's a lot of active virus around, quieting inflammation can let virus grow. So you have to, it can be a very tight balance. But the overall disease process really affects most every body tissue. In terms of how I got here, and I said I talked a tiny bit about radiation. When I was a kid, I had a bone cancer about 40 or 45 years ago, and had radiation. And then about 10 years ago, had some complications from it with wounds that wouldn't heal, and had a bunch of surgeries, got it all better. And then still ended up having some ongoing inflammation here and there. And then in 2020 had COVID. And then in 2021, in the winter of 2022, started trying to take something to keep my leg from getting more wounds or opening up again. And after looking around a bunch, decided to try something called metformin. I'm not diabetic, but there were a lot of reasons why it seemed like it would make sense. And I noticed about 6 or 8 weeks after taking it that all of a sudden I could multitask better. What I would describe as brain fog that I didn't even really know I had. I thought I was just getting old. All of a sudden, it really kind of cleared up and has stayed away. And from that, started diving really deeply into what is this long COVID thing and chronic fatigue syndrome, and what's it look like. And this is off my iPhone. I just pull articles and then hang on to them. There are about 3,900 of them. And the stuff is coming up all the time. And right now we're in another spike of the disease. So from a mechanistic standpoint, long COVID, and I'm going to dive into started a broad mechanism and zero in closer and closer in on the body and get to that place of the seesaw on the white blood cells. But the thoughts are that there could be a viral reservoir. So you might have a reservoir in your gut of virus that's hanging out there and continuing to replicate, and so making more antigens or more irritants that keeps an inflammatory process going. It might be autoimmunity, where your body is attacking itself, and so that keeps inflammation going. The dysfunction and damage in the tissues itself could be a part of the root cause, and that would be the example where small vessel diseases, you end up with what are called nets from white blood cells, and you end up with the endothelium or the lining of the blood cells getting damaged, that then causes some leakage and causes histamine release from what are called mast cells that sit just outside the blood vessels. And that histamines give you rashes, histamines cause inflammation, and they also activate, you can activate platelets, and so you can get further microclots from activated platelets. And then latent virus reactivation are things like shingles and Epstein-Barr virus, the old kissing disease, that those seem like they may reactivate in many people. So it's not uncommon to get shingles after having with long COVID. And then right now, this article, there's a very comprehensive article in Nature this month that kind of updates everything about long COVID. And at this point, the economic cost is probably around $1 trillion. I said that before, there's about 400 million people in the world and about probably around 20 million in the US. But bottom line of what happens is the virus goes in, you get inflammation, that inflammation, depending on where it hits, whether it's in the gut or the brain or somewhere else, or changes the energy within the cell, the mitochondria, all those things can end up with different symptoms and triggers. At the body level now, so this is a blood vessel here, and then what happens at the blood vessel and kind of around the blood vessel. And I'll flip back to the other one just to put it in context. So the here, if we're looking at a blood vessel and things coming outside, we're now zeroing in on this smaller area. We all hear about the ACE2 receptor that the virus connects to, and that makes it plug into the endothelial cells and it starts causing inflammation. You have breaks between cells, and when that happens, the virus can get in and interact with other cells. So this is looking in the brain with microglia activation, which are the white blood cells in the brain that are part of the immune system. And it connects to something called TLR4, which is there are a whole series of sensors on cell surfaces and sometimes inside of cells. And TLR4 is one of those on the cell surface. And when those cell receptors get turned on, it starts an inflammatory process because it's saying, hey, there's danger. They're danger-associated receptors. And then that danger says, light up the immune system. And unfortunately, what happens in long COVID is the immune system lights up and ends up in an overactive space. And parenthetically, people talk about chronic Lyme disease, and that has TLR2 is the one for chronic Lyme, but it turns out that that goes in the same direction and starts this underlying process where this thing called the NLRP inflammasome ends up lighting up, and that starts where you get the release of the cytokines. And those cytokines are good because they can get rid of invaders, but they're bad because they can cause death of important cells too. And so at the normally you have the endothelium. Now we're at a single cell level. You have the endothelium, and it works to transport nutrients and maintain the matrix, and it kind of keeps everything moving right. But if it gets induced with these DAMPs, these danger-associated sensors or bacteria, the cell wall of gram-negative bacteria, lipopolysaccharide, is really good at turning on TLR4. Then it damages the endothelium, and then from that you get the body producing inflammatory cytokines, these IL-6 and tumor necrosing factor and so on. And then you also end up with issues of blood flow caused by impaired vasodilation. So the vessel constricts, it gets fibrotic. Back to that radiation piece, radiation causes fibrosis as well. And there kind of are two ways it can go. You can activate the endothelium, and it just releases its proteins, and so that are already there, and then that activates the platelets. Or you can activate it, and it starts a little factory going to produce these cytokines, and that seems to be what happens in long COVID. And then this picture on the right is really describing that kind of a process. This is from a different article. But then when the macrophage gets activated, this is the impact on the heart. And so it can cause at a broader level, it can cause ischemic heart disease, where the big vessels get plugged up. That usually doesn't happen as much from long COVID. It's more those small vessels, the micro vessels. But when a bunch of them are clogged up or inflamed, then that causes lack of oxygen, and so you can get chest pain from it too. So that we see things in chest issues, kidney issues, lung issues, brain issues, GI issues, and so on. So now we're going from the general tissue down to inside and outside of a cell. So you have these toll-like receptors. Usually it gets turned on during sepsis, but it turns out that SARS-CoV-2 is sort of tricky. If you put three spikes together, you end up with you put three spikes together and you end up with a great skeleton key that fits TLR4. And it turns out that Ebola virus and RSV also can do this trick on TLR4. And it may be why we're seeing a lot of respiratory syncytial virus has occurred also as we're in this whole post-viral period, post-COVID period. But anyway, once the toll-like receptors are turned on, then there's a series of steps that happen inside the cell, something called the RAGE pathway, and then it ultimately ends up creating proteins associated with that create chronic inflammation. And what happens is there's a trade-off. There are two types of white cells, M1 white cells and M2 white cells, and there are in macrophages and monocytes, which are what get infected. And the M1s tend to build up, and the M2s are killer. I might have just gotten that backwards. I get dyslexic sometimes, and I apologize. But the teeter-totter of M1, M2 is the back and forth, and it's driven by something called NRF2 that goes into the nucleus. Then you end up building out or making more builder cells. And if you do HIF1, you get more killer cells. And by the way, some of the treatments, for example, for MS are specifically aimed at quieting and are driving NRF2 up. And so that's a clinical strategy to get more NRF2 that will decrease the chronic inflammation. And that's sort of a takeaway. And then these toll-like receptors or these danger sensors, there are also some that happen inside the cell as well. And TLR3 is related to this process too. So sometimes in COVID, you'll hear that come up. So now, if that's the basic science, if you back way off and say, well, what can you do about this from a treatment perspective? And this is sort of the four-step process that I subscribe to, and I'm certainly not the only one, but to try and approach this from a systematic perspective. If the issue is that these small vessels get blocked, and when you block small vessels, you lose oxygen, and when you lose oxygen, you create more inflammation, which creates more blockage, then you want to get blood flowing, and you also want to quiet down the inflammation. And if the inflammation is getting caused by the virus in the first place, you want to get rid of whatever's causing the inflammation. So whether that's the virus, or you end up also sometimes getting leaky gut that occurs. And so getting the microbiome and the bacteria in the gut to the right level is important also. There are things called short chain fatty acids that are important in the gut to quiet down and get used as raw material. But start by tackling the virus reservoir, then go after quieting the inflammation by quieting down TLR4 activity. And there are things like curcumin does it, which is the active ingredient in turmeric. Metformin, the drug I happened to land on for my own trying to prevent a chronic wound from recurring years ago, but it's been game-changing personally. And then there's a supplement called berberine, which is a close cousin of metformin, but doesn't require prescription. There are things like very low dose lithium, where 300 milligrams is what's used if somebody has bipolar, but 10 milligrams is enough to quiet down TLR4. Melatonin does it. There are a number of ways you can quiet down TLR4. And then to get the blood flowing again, you get these little clots, these amyloid clots, and that are microclots. They're not too much bigger than a few hairs. And you want to try and break those up And so there are things called proteases. Nattokinase is a really easy one. The Japanese diet has a lot of natto in it, but you can get nattokinase as a supplement, and that's shown to be effective in a number of patient surveys of people people will do surveys and say, well, what works? And one of the things that tends to show effectiveness is these kinases, lumbrokinase, nattokinase, and so on. And then when you get inside the cell, the energy area, which is where mitochondria comes in, can get disrupted. And there are a couple things you can do. One is to say, hey, if that's all disrupted and is in a sort of zombie state, then try and force the cells to break apart, and which is to push autophagy, which is recycling, or apoptosis, but the cell stays alive. You recycle some of the bad parts inside, or apoptosis, which is where the cell itself bursts and dies, and those things recycled. You can lower the senescent cell burden, and there are ways to do that. There's a supplement called ficitin that comes from strawberries that turns out to be really good at it and really well tolerated. So repeating and seeing it in words, that the TLR4 on the white cells in the endothelium is attacked by the spike, invades the monocytes, triggers the receptors. There's upregulation of some ACE2 on the receptors, and it creates the M1 killer polarization. And so it's useful for new blood vessels, and maybe that's why when you have low oxygen, hypoxia, you get inflammation. And when you get inflammation, it creates more of these M1 killers that tunnel, because inflammation will also tunnel and start the creation process of new red blood cells. But it will also do things like screw up your joints and rheumatoid arthritis, or importantly, mess with the blood vessels throughout the body, is what we're seeing in post-COVID. So it's really quieting down the chronic inflammation, and which is quieting down the cytokine production. And again, it's very similar to wound healing. And in wounds, you get people in a non-healing state, and it's these same processes that kind of flip it over to the healing state, where you need the breakdown state to pull the crud away, and then at that point you need to flip over to the M2, to the healing state, where you lay down new material. The M1 state drives this thing called HIF1 into the nucleus of the cells. It happens when you have the white cells in the M1 state, and it also changes the amount of energy available. The one thing that shows up in long COVID is chronic fatigue, and there are two ways the cells make energy. That's a little more complicated than that, but roughly there's the Krebs cycle or tricyclic TCA cycle, or there's glycolysis, and TCA is much more efficient. You get 36 energy units instead of about 3 through the glycolysis, and the killer HIF1 pushes more glycolysis. So you also, as you go to M2, you push more of TCA and better energy. HIF1 is lowered by metformin. It's lowered when you increase oxygen flow. It turns out that melatonin is helpful for it as well. Something called low-dose naltrexone can be helpful. And this really is the bottom line is, if you think of a kid's teeter-totter and HIF1 and NRF2, you have it as a balance, you're good. And if you're slammed all the way on HIF1 up, then you have too much inflammation, your joints hurt, your blood vessels aren't working that well, might be protective of cancer until the cells get screwed up, and then their DNA gets messed up and they can create cancers. And on the other hand, if you have just the NRF2 up too high, then don't have inflammation going on, you can get rampant viruses and potentially cancers. And so that balance is really important. And a lot of it happens through this thing called an NLRP inflammasome. And I'll finish up here in a moment with a particular sort of clinical path, and then open it up for questions. And this is the cyclic issue. I talked about it. The mast cells come into it, so things like antihistamines are useful. Platelets come into it, so aspirin to be helpful. Turns out heparin is helpful, not only to keep low-dose heparin is in some cases can be very helpful, not only for the platelets, but also one of the pathways on that MD88, when you were inside the cell, the RAGE pathway is quieted down by heparin. And for TLR4, which is sort of seems to be one of the main places that it matters of quieting it down, that curcumin, metformin, or berberin seem to really work. And it's interesting, boron may be something very useful also. And then after this has been going on for a while, you end up with senescent cells. You certainly end up with senescent cells in aging. And so ficitin is a way you can get some of those zombie cells to, instead of just hanging out as senescent cells, to break apart and recycle. So stop the virus, limit the inflammation, prevent the microclots, treat the microclots, and restore the oxygen blood flow. And this is just a mnemonic for it, goes through the same thing. And from a pictorially, the same kind of a concept. And overall, one of the goals that I've got is to try to say, how can we do this at scale? Because right now there are tons and tons of people that have the issue, but aren't even declared as having it. It's, you know, I mean, in my own case, where I just thought I was getting old and then found out that, oh, taking something could end up making a significant difference, and feel back to the same of being able to multitask and do what I was used to doing 5 years ago. But there was a few-year period in there where it was just really hard to do it. And their thoughts are at least a couple million people in the US, if not significantly more, are out of work, and a lot of people are losing productivity. So I will stop there and open it up for questions. I think that's about the right amount of time for the prepared remarks, and happy to answer any questions and dive more deeply into where it makes sense.